Good evening, everybody. Thank
Hello.
you very much for attending the teaching today. We have a very interesting subject. Dr. Omar will talk about approach to raise troponin, which is really interesting and a very big question almost every day in any ward. I hope you enjoy it, and over to Dr. Omar Assaf.
Hello, everyone. My name is Omar. I'm one of the IMTs in Royal Preston Hospital. A little bit short introduction about myself. I was a cardiology research fellow in Blackpool, which is a tertiary center for cardiology, and all of my experience prior to be practicing medicine in the UK was in cardiology. I just picked this topic because there's a lot of referrals to cardiology regarding raised TROPs, whether this is type 1, type 2, whether start anticoagulation, antithrombotic treatment or not. I think I just picked this topic just to make for two purposes, basically. One, for patient safety, on which to select how to interpret the troponin levels in different contexts of clinical scenarios, in order either to avoid overprescribing of antithrombotic agents and avoid complications, or even not to delay it based on this is type 2 MI. And the second thing is the physicians themselves safety, because everyone needs to be comfortable with their practice, need to be able to give the adequate recommendations based on an evidence-based medicine, and also understanding what's the background and why this is a big issue and why there is a universal definition of an MI for specific reasons. So just a little bit of an background. Basically, the first time that there was discovery that the term myocardial infarction was due to coronary thrombosis was late in the 19th century in the postmortem examination. And the first description in the literature going back to associate coronary thrombosis and myocardial infarction together was back in the early 20th century. Although despite that, it was not widely used by clinicians at the time, because there was a post-mortem study that only showed that there was 31% of patients with myocardial infarction didn't have a coronary thrombosis at all. And as a result, since that time, several definitions has been implemented for myocardial infarction, and it caused a lot of confusion as well and controversy. So I'm just going to share all of this. What I'm going to share now is based on the European Society of Cardiology guidelines for myocardial infarction, and also for the non-ST acute coronary syndromes as well. So that's a slide from the European Society of Cardiology from the fourth universal definition of MI, which was published in 2018. Just an approach and idea, and you can see that there is different definitions published. So the first one was nearly around the late 1950s by the WHO, and then there was a fifth definition by the WHO at early 1970s, and then another one by another society, and another one by a different society. And then from 2000s, there started to be redefinition by the European Society and American Society of Cardiology on their own as an outlier to the other societies. And then the agreement has occurred between all societies, basically, to have a universal definition of an MI at around just before 2010. And since then, there has been multiple universal definitions, and this is the latest one published on the fourth definition of the fourth universal definition of myocardial infarction in 2018. So it seems to be like we've been a century based, less than a century, trying to get a universal definition, so we can try to unify the practice and make it a standardized practice around the world in order not to miss a myocardial infarction. This is a slide regarding what it's called the myocardial injury. So I want to say, if anyone wants to ask a question, just they can feel free to interrupt me at any time. I do not have any objections, but because I just have the slides on my screen, I just cannot see everyone as well. So it starts with the myocardial injury, the myocardial infarction. And there is a differentiation between both of them, and that's where the universal, what's the part of what the universal definition of myocardial infarction wants to state. So if you see a rise or a fall of a troponin level, that's basically suggests a myocardial injury, but it needs to be either acute or chronic. So, and that only is based off if I give you a blood result, full panel of blood results, and there is a troponin, and you see a raised troponin. So you can safely suggest that there is a myocardial injury, but you cannot suggest that there is a myocardial infarction, because you don't know the context of the patient, you don't know which type of myocardial infarction it is, and you don't know what's the trend of the troponins as well. So that's the first part, is that there is a myocardial injury. There is a concept called myocardial injury. Am I going too fast, or everyone's just aware of everything? And is everyone hearing me well?
Yeah, I can hear you well, Omar.
Yeah.
You're a
Yes,
bit fast, but
definitely you are
I'm
going too
catching so
fast.
far.
Yes, definitely you are going too fast. I'm not understanding anything because
Okay.
I am ANT, but yeah,
Okay.
carry on.
So
We will see at the end.
So do you want me to go back from the start?
No, I'm still. You are still in the definition of the myocardial infarction.
Yeah.
Changes in the definition since I think 19th or.
So is the slides not working? You cannot see my slides moving?
No, I saw it since 1950. Okay, no problem. Carry on. No problem. I will ask you at the end if there is anything that I'm not understanding.
Okay. So can you see the slide now? The one with the epidemiological approach of the myocardial infarction.
Yeah, all these are regarding the definition.
Yeah. Yeah.
Okay.
Yeah. So the first bit is the myocardial injury. So the first part that the guidelines want to stress on is that there is a difference between a myocardial injury and a myocardial infarction. And the first part, this is a screenshot basically from the guidelines. Is describing that a rise or a fall of one value above what is the upper reference limit is enough to say that this is a myocardial injury. Now it can be acute if you can see a trend of a rise and or a fall, so you can see it late at the presentation or early at the presentation. That's why there is a rise or a fall, and that's why falling is mentioned in the definition. Is that okay?
I just have a quick question,
Yeah.
Omar. Fall in a raised troponin, not fall in a normal range, isn't it?
Yeah, fall. So you need to have a fall in raised troponin. That's true.
Yeah.
Okay. And then moving on, this is a diagram just trying to show the most common stressors that can lead to can come out from no effect at all on the myocardium to a myocardial injury to a myocardial infarction. So if you look here, can you see my mouse moving? Yeah, can you see the cursor? Yeah. So basically, this is a slide that the European Society of Cardiology tried to say that these are the most common causes to have stress on the heart to cause a myocardial injury or a myocardial infarction. And the outer circle here is basically there is no involvement of the myocardium. And then the inner circle here is the involvement, but there is an increase in the troponin levels in the bloodstream, and that is a myocardial injury. And then the third circle here is basically an involvement of a myocardial infarction. Involvement of the myocardium to the extent of an infarction. So someone can come with an anemia to the extent that there is no problem with the heart at all, but it can be significant enough to cause a rise in the troponin, and it can be significant enough to cause an infarction. And also the ventricular tachyarrhythmias, which is someone can come with which is very common. And there is heart failure. Someone can come with a heart failure presentation, for example, as a lower limb swelling only, and you can check their troponin. They might be not raised, or even can be raised only at this part, or can be raised significantly here. And then CKD as well, hypotension and shock, hypoxemia, and so on. So that's basically a diagram that the ESC trying to show in it that the stress, these are the most common stressors outside of an atherosclerotic or a plaque burden that can cause secondary causes of myocardial rise and myocardial injury, and that can lead to a myocardial infarction. Is that clear? Or do anyone has any questions?
Yeah, it's clear for me.
Now, this is the fourth. This is basically a screenshot of half of the definition. There is a lot of information here, but I'm going to break it down in the next few slides. But basically, the one I'm putting this here just to get one thing to take away from this slide. The universal definition of MI constitutes that you need to have a myocardial injury, which, as we were discussing in the 2 slides before, as an elevated cardiac troponin values, at least one value above the upper reference limit. Now, this myocardial injury can be considered as acute if you can see a rise and or a fall even of the trend of the values. Now, beside that myocardial injury, you need to have one of these following. So what is so you need to have the rise or fall, and you need to have only one of either symptoms of myocardial ischemia. So if you've seen a raised troponin and symptoms of myocardial ischemia, it is enough to qualify this as a myocardial infarction. You can find a rise or fall of troponin with a new ECG changes. You can see a rise or a fall with a development of a new pathological Q waves, or in imaging evidence of loss of a viable myocardium. What does that mean? That basically means if someone had an echocardiogram 2 years ago and it was fine, and basically he had a repeat echocardiogram because of this rise troponin and shows heart failure, then there is definitely infarction that occurred with the patient. Or something called new regional wall motion abnormality, which is something specific to cardiology for imaging. We can skip that. Or also you can find a coronary thrombus on angiogram or on autopsy. So this is universal for the type 1 and type 2 and type 3. What has changed in the guidelines, or what has changed in that definition, is that it expanded the myocardial infarction types to 5 types. So the type 1 and type 2 has been there in the literature in the previous definition, but it expanded furthermore in different types. The reason that there are types now, because you need to understand that there is a difference in the thresholds to qualify giving ACS treatment in certain situations. And we're going to go through them in the next slides. Is there any questions regarding this part that I said?
Yeah, again, about the value, I'm not very good about understanding the percentile. So is it like one-fold?
So it at least one value. So the guidelines, I put the link of the guidelines at the end of the slides, but it basically, I went and read into what does this qualify into. It doesn't need to be false. Is as long as the lab, the local lab that you're working with, first is using high sensitive troponin. That's very important. Second is that if it's raised by, for example, let's say the upper reference limit is 20, so it's above 20, then there is a myocardial injury. Now you need to qualify that above 20, and there is one of these, you can consider that this patient is having a myocardial infarction. Obviously, if you've seen it that low, it's either you've seen it too late, when the troponin is just getting lower and lower and lower, or you've seen it very early, just before the troponin is peaking.
I mean, if I found a patient with my lab giving the upper limit as 20, if I did a troponin and it's 25, this is a raised troponin. And
that's qualifies as first as a myocardial injury, and then you want to know whether it's acute or not. And I'm expanding more on that bit of acute and chronic rise of the troponin in certain contexts furthermore. But yes, this is basically a raised troponin, and there is no need to say that this is double fold or not or 20% more, because this is basically your first value that you have seen on that presentation for the patient. For example, this patient has been admitted multiple times with chest pains, and all of them has been non-significant. But this admission, you've seen the patient on the take or from ITU perspective, and you did a new troponin in this admission, and the new troponin in this admission is 25, and the patient is having myocardial ischemia, symptoms of myocardial ischemia that you are convinced that this is chest pain of cardiac nature. Then the patient is having a myocardial infarction. Now, this is not the question. This is only part of the question. The second part of the question, it is which type, and the reason it's important is because there is different treatments, or not different treatments, different interventions that can really and improve the prognosis.
Let me ask a question, please. I'm sorry, I'm interrupting you. Raised or dropping troponin compared to what? If it's raised, okay, compared to the reference value of the lab. But failing troponin, if it is the reference value is 20, the value is 18. So maybe it was 25 before and now it is 18.
So it is fallen compared to a previous raised levels.
Yeah, that's fine. Okay.
Okay.
Yeah. Okay. But you said that we may discover the myocardial infarction late. So this patient may first come presented with a late presentation.
Exactly. So that's what they want. Yeah. Go ahead.
No, sorry. No, carry on.
No. Go ahead. Sorry, I'm sorry to interrupt.
Yeah. So this patient came with maybe failing troponin, came late, presented late. So in this case, how do you know is this failing troponin or raised troponin? If it's 21 like this, yeah.
I'll give you two examples. For example, this is the first troponin for the patient in the hospital, and it's 21. And the patient is coming complaining, for example, that he's been having shortness of breath for the past couple of weeks on exertion. And this gentleman had an echocardiogram, showed heart failure. So you can basically justify that the patient had an infarction and the troponin is only mildly raised, because he must have been presenting late, because he's now also coming with the symptoms of heart failure, not only ischemia. If you've seen, there is something very famous that I think Mohsen can relate to as well. For example, patients can be seen by ED or even seen by medics and then seen by ITU afterwards. And the physicians who have seen the patient at the time seen a raised troponin and said that this is type 2 MI. And for example, the type 2 MI, the levels were 120 and the upper reference limit is 20. And the patient is coming with shortness of breath, and he was found to have pneumonia as well. But when Mohsen saw the patient, because the patient was escalated to Mohsen, for example, as an ITU physician to admit the patient to ITU, Mohsen repeated the troponin again, but the troponin 1 day later was actually 40. So that's a massive drop. In a chronically raised troponin, you will not find that massive variation. So if there is a fall, that's why the definition is just stressing on the fall bit. So there is a trend of fall that is not suggestive that this is of a static nature.
Yeah.
Does that make sense?
Yes, it makes sense.
Yeah. So you can see that patient in two different contexts, as if the first one and the patient actually has already had the myocardial infarction for 10 days, and you only had the coincidence to see only a mildly raised troponin, but it was actually a late presentation of the MI. And you can come and see that patient after being admitted for 2 days, and it was actually missed as a type 1, and someone interpreted this as a type 2. And when there is a massive difference in the doesn't need to be massive, but there is a dynamic difference from the baseline troponin, even dropping down to 60 or 80, then you need to consider that this patient is having an acute rise or fall, which can, in clinical context, be considered as a myocardial infarction. Does that make sense?
Yeah, it makes sense.
Yeah, I'm going to further examples that will make sense furthermore as well, but just this is the start of the definition, basically. Now, I'm only reviewing here type 1 and type 2 and type 3, and I'm going to detail them in different slides to make things easier as well. So that's a diagram that's basically the ESC is trying to show the pathology behind the type 1 MI. So this is this is the LED, basically, the left anterior descending artery, and you can see that the rest of the heart muscle is appearing as red. And now here there is a blue coloration around this vessel, and there is a highlighted area here. If you come and look into that highlighted area here in the vessel on the right side, you can see that there is a plaque rupture in the lumen. And that's why there is an occlusion in the vessel, and that's why this part is becoming infarcted and it's appearing as a blue color. If you look into the infarction itself, it can sometimes occlude the full length of the vessel, or the full width of the vessel, sorry. So it is a complete occlusion, and this part is the STEMI. and it can only be partially occluded or can be considered as a non-inclusive thrombus, for example, and this is the N-STEMIs that basically everyone is talking about. So in this type, this is why this is important to qualify as this, to quantify this as a type 1, is to give an ACS treatment, because this is the primary pathology behind type 1. So if you go down back into the definition and then you found a raised troponin or a fall of the troponins, and you've seen either an ECG changes or symptoms of myocardial ischemia or a Q waves or a new heart failure, then you need to consider that the patient is having a type 1 MI if you're convinced that there are no other causes to explain the patient's symptoms. Now moving on to the next slide, and this is just basically the criteria on its own for type 1, clearer away from that big slide. So also the same thing, so detection of the rise or fall of the troponin lies with at least one of the values above 99th percentile. And you need also one of the following things, but in a type 1 MI, you need definitely to find a coronary thrombus, either when the patient is having an angiogram or an intracoronary imaging as a CT coronary angiogram, or if the patient it's found on the patient on autopsy. But in the other types, for example, in type 2, you will not find a thrombus in the patient. Is that clear for type 1?
Yeah, it's clear.
And type 2, for example, here, this is another diagram, the same thing, the same area of infarction, but there is no occlusion in any of the vessels. And then this diagram here, this example is trying to explain what is the context of type 2 MI. So basically, let's say, for example, myself, I came to the ED and I had an attack of an AF, and the AF was very rapid, running at around rate 180, and I'm coming with a chest pain. So why I'm having a chest pain at the moment? It can be I'm having a type 1 MI because I'm living an unhealthy life, or it can be due to the tachycardia. So what happens if someone has a significant tachycardia? What actually will happen is that the heart is beating too fast. So the demand of the cardiac muscle for oxygen is very high because it's doing a lot of effort to beat at that rate. But what happens is that the coronaries doesn't have time to be filled up with blood, with the same amount of blood that it is filled up when someone's heart rate is 60. So now the heart rate is tripled. So there is no enough time to fill the coronaries. So there is a mismatch between what? Mismatch between what the cardiac muscle needs to get the blood flow that the cardiac muscle needs to get oxygen, and actually the amount of oxygen supplied by the coronaries, because there is a reduction in the blood flow due to the tachycardia. I might have, my blood pressure might actually be 110/70, but I'm coming with a chest pain. And that means that possibly when they do the troponin in my case and they can see that this is elevated, then I'm having a type 2 MI because there is a tachycardia going, shortening the time of the diastole, so shortening the volume of the blood pumped into the coronaries, so not giving the heart muscle the enough oxygen it needs to pump out the blood. And these are 4 other different mechanisms. Basically, they're trying here to say that this is a healthy vessel, but this healthy vessel can have what they call a non-atherosclerotic coronary dissection, which is basically mean a dissection for some reason, whatever the case is. Let's say it's spontaneous. So what happened is that the lumen changed from all of that width to only this width. So there is a reduction in the blood flow for the cardiac muscle because actually the lumen capacity has decreased, as you can see here. So the patient can start to complain of ischemic symptoms and can have an infarction. But because the infarction is not driven by a plaque rupture, like this slide here, you cannot see any plaque inside of the or plaque erosion blood vessel. So it is called type 2 MI. And someone else, for example, let's say very famous patients who are addicted to cocaine are very liable to have the coronaries to have vasospasms. So when they have a significant vasospasm, you can see how much the reduction of the lumen width is. So there is a reduction in the capacity of the lumen to carry on the blood here. So there is also the patient complain of a chest pain and can have an infarction, but it's secondary to a vasospasm. There is another one that's famous, and it's very difficult in clinical context, and I will show a case that actually had the same thing. This, you can have a patient, let's say 70 years old, type 2 diabetes and oral hypoglycemic and hypertensive. And this patient might have an element of atherosclerosis ongoing actually, but it's very stable in nature. It is basically gradual narrowing by year by year to the extent that the lumen is only narrowed to that extent, but the heart can accommodate the needs based on that narrowing of the lumen. So that patient has an underlying already a mismatch, but this mismatch is masked. So if that gentleman, for example, or if that lady went into an attack of hypertensive emergency coming with a systolic blood pressure of 220, so then the pressure of the heart on the heart muscle to pump the blood will be higher. So it will require more oxygen, but it will not be supplied by this narrow lumen. So the patient will have a type 2 MI, for example, or someone is coming with a bradycardia, like someone is coming with a heart block, and they coming and you did a troponin and you found that the troponin is 250 or 300. Because there is actually narrowing, and even when you lower down the heart rate too much, the vessel didn't accommodate the lower heart rate, and the amount of the blood supply to the heart is lower, so the patient has a type 2 MI. So that's why it's different. It's completely important to differentiate between a type 1 and a type 2. The idea is basically type 1 is driven by a plaque rupture. That's the primary thing, and that's why you give the patients aspirin and P2Y12 inhibitors, which are clopidogrel or ticagrelol, and you give them low molecular weight heparin, and the idea is to stop the thrombus from aggregation. But the other type 2, is basically due to an underlying other mechanism. Either the patient already has a narrowing in the lumen, but it's stable, but something as an external stressor, like an acute anemia, or like hypoxia, or like a tachycardia, or like a bradycardia, unmasked this mismatch. So the patient is complaining of a type 2 MI, or someone had a vasospasm, or someone had a dissection in an already healthy vessel like this one. Is this clear, or does anyone have any questions regarding that explanation?
Sorry, I may miss this. How the patient will have type 2 MI in a normal vessel like this one?
So no, this one. So this is basically a picture
just for a comparison. Yeah.
Yes, for comparison. Yes.
Yeah. Sorry. Okay.
Yeah.
Carry on.
Okay. Yeah. So and then this is basically a diagram trying to illustrate the context. Basically, if you look here at the end of the screen, sorry, this may be a bit jammed here, but it was what this sentence trying to say, that I'm, for example, might have type 2 MI due to a very minor change in that stressor, and someone else can have an MI due to a significant change. So it's just basically trying to say that the ischemic thresholds vary from a patient to the other. Depends on one, the magnitude of the stressor. So for example, the magnitude of the tachycardia, someone can develop a type 2 MI due to tachycardia of 120 beats per minute, and other one can develop a tachycardia to a heart rate of 180. But it's also not even, and it's also depending on the underlying cardiac disease as well. So it's very variable, and that's why they are going into in depth into the explanation of the definition. And here, basically, you're starting with a type 2 MI. They're trying to say that there is a context. The context is that it is secondary to another illness or secondary to another process. But this secondary process is leading to a clinical presentation that it's of a cardiac nature, which is a chest pain. And then afterwards, the mechanism is basically built on the supply and the demand of the oxygen to the myocardial muscle. And the supply and the demand by the myocardial muscle is basically driven by the coronaries. So if something happened with the coronaries, affecting the coronary filling volume and time, then the patient will develop type 2 MI. But it depends on the magnitude of the stressor, as the slide is trying to say here, and the underlying cardiac disease of the patient. So for example, someone can have a very good control of his diabetes and a very good control of his blood pressure, but he's been having them for a long period of time. He has a fixed coronary atherosclerosis, which is fine based on his baseline effort and performance. But once this patient has a high blood pressure, significantly high blood pressure, or a hypotension, or develops an acute anemia, or develops an acute bleeding, starts to have an ischemic symptom, symptoms, and then the mismatch between the oxygen supply and the demand is there, then the patient develops a type 2 myocardial infarction. And then these are the different, most famous different mechanisms of type 2 MI, mainly the hypotension and shock, the severe anemia, respiratory failure, bradyarrhythmias or tachyarrhythmias, or severe hypertension, or coronary dissection, which is obviously no one will be able to diagnose it in the A&E. You need an angiogram to know that, or a coronary embolism, which needs an angiogram to know that, or a coronary spasm, which also needs an angiogram to know that. But these are basically contexts of another process of an illness causing the patient to have a mismatch of the oxygen needs and the supply in order to have a type 2 myocardial infarction. And at that point, giving these patients an antithrombotic treatment is not indicated as a loading dose, for example. So you don't need to give them the 300 milligrams of aspirin, or the loading dose of the P2Y12, or the treatment dose of the low molecular weight heparin. Does that make sense?
Sorry, you said coronary embolism.
Yeah.
This would be a type 1.
So coronary embolism can be very rare cases of even the fat embolism can go into the coronaries. You can have an air embolism, iatrogenic, when patients do an angiogram, and when we are juniors in cardiology and not preparing them, for example, the injectors quite well.
I mean, this will be a sudden block of blood flow.
Yeah.
And should be type 1, not a type 2.
So a sudden block, you don't know. So you have a sudden block in the vessel.
Mm-hmm.
The patient will come with an ischemic symptoms. This patient will be rushed to the cath lab, and then it will discover to be as an embolism rather than an infarction, because when you
I mean the impact on the cardiac muscle will be the same, either thrombus or
all
embolism.
of them. So all of them will have, all of these situations, the patient will have an infarction. So the result on the cardiac muscle will be, just 1 second. Yeah, will be here the same. So can you see that blue area? That's basically an infarction. So the patient already had an infarction already. But that infarction, the treatment of that infarction is not to give the patient in a coronary embolism situation, not to give them an antithrombotic treatment to relieve that embolism, which is very difficult to do, by the way.
Yeah, I mean, this infarction has some characteristics to point to that is a type 2 and not to use antithrombotic medications. But with the embolus and thrombus, all of them were occurring all of a sudden, and I don't know. You said that you are happy with the questions.
I think
maybe, I'm not
explained in the future.
No, I'm not bothered. No, I'm not bothered at all. Go ahead.
Sorry, Omar. I think the confusion is coming from that you are looking at the end result, Ahmed. But what Omar is trying to say, the pathology is different. Type 1, you must have an atherosclerotic plaque that ruptured and caused obstruction. It's not the obstruction. Yeah, all of them will have an obstruction. Type 1, type 2, type 3, there will be some sort of a blockade. But for type 1, you must have an atherosclerotic plaque that has ruptured and caused the obstruction. In type 2, it's some different pathology.
Yeah, I mean that from what you said, Dr. Omar, that type 2 is a mismatch between supply and demand. So if the patient has infarction, still there is a small amount of blood escaping this stenosis and goes to the cardiac muscle, and still there is a supply of oxygen going on, even if it is still low behind the demand of the cardiac muscle. But in case of thrombus and embolism, all of a sudden, all the blood flow will be stopped, and not even 1% of the cardiac muscle demand for oxygen will be delivered.
Okay, so just one thing regarding the thrombus, and then I will go to the embolism. You can have and thrombus that's not occluding the full length of the vessel, as you see here. So that's the luminous patent here. There is still blood going on there. There is a blood still bypassing the thrombus here. And that's the difference between a STEMI, so which is a complete, it comes from a complete occlusion of the vessel, and an N-STEMI, which is basically that the ECG doesn't show an ST segment elevation because there is a partial occlusion of the vessel. Now, the partial occlusion does not need to be angiographically when we take pictures of the angiogram. to be, for example, in my eye, significant enough. It only needs to be significant enough for the patient to develop an infarction. And that's why the next slide in the type 2 MI, this bit is very important. So I'm as a patient, or someone else as a patient, can develop an infarction because of a certain occlusion different to the other patient. So I can have 1/3 of my vessel occluded and develop a chest pain and STEMI, and someone else will not present with the same symptoms unless they have a 50% or more or 70% or more occlusion. Does that make sense?
Okay.
The idea is not the vessel for this patient to develop an infarction. The idea is the heart muscle itself. Does it feel strained, and does it feel in need of oxygen more and more? That's how you develop the chest pain. So you develop the chest pain.
Yeah, carry on. I'm sorry. I'm still confused between the type 1 and type 2. Yeah, if there's no, yeah, so
I know where the confusion is coming from. So regarding this bit and that bit and that bit, these bits are unfortunately going to be discovered only by a coronary angiogram. Just moving away from the spasm, moving away from the embolus, moving away from the dissection. If you have a sustained tachyarrhythmia for the patient, or a severe hypertension, or a severe bradyarrhythmia, or a respiratory failure, or a severe anemia, or a hypotension, any of these stressors moving away from the embolus and the spasm and the dissection, then you will find that in this healthy vessel, depending on how bad that stressor is, this patient will develop an MI. How? For example, in the case of a tachyarrhythmia, if my heart is actually sustained to feel well perfused on heart rate range of from 60 to 120, so I will not feel any ischemic symptoms. But if I go and my heart rate goes high to 150, 180, this might be significant enough for me to develop an ischemic symptoms. How? What happens in a tachyarrhythmia is that the heart is beating too fast. So one thing will happen, that the oxygen demand will get increased by the heart muscle. Second thing, the supply is not the same, because what happens in the tachyarrhythmia, the heart is beating fast, so the period that the heart fills itself with the blood is shortened, because it needs to beat in a minute. So instead of beating from 80 beats, it beats in 150 beats. So the amount of volume coming out from the heart is less. So the amount of volume passing to the coronaries is less. So that's basically the mechanism, that the tachyarrhythmia has decreased the filling time of the heart and increase the heart oxygen demand. So as a result, there is a difference in the scale. The scale is higher towards the oxygen and the scale is lower towards the supply. So that's why it's a type 2, because the primary pathology is not driven by a thrombus, it is driven by a mismatch in the supply and the demand. Does that make sense?
Yeah.
And also the same in hypertension. So what happens in hypertension is basically look at the aortic valve as if it's a door, and the heart and the ventricle is a person trying to open the door against a very high pressure. So what happens, they go and strain and they go into a red color. That means that they are struggling. So at that point, the heart needs to pump out the blood with an extra pressure, but it cannot do so because already the amount of pressure is building up because of that hypertension. So the oxygen supply is the same because it's pumping still blood, but the demand is much higher because of the amount of the pressure, because of the hypertension. So as a result, there is a mismatch as well at the end. And also in hypoxia, for example, someone who's asthmatic and coming with a type 1 respiratory failure, or someone is a COPD patient and they are coming because they are acutely unwell. So there is no difference in the coronary supply. The coronary supply is fine, but actually there is no enough oxygen going through the coronaries to the heart muscle because the lungs is hypoxic.
Yeah.
Does that make sense?
I understand this. It is clear that the type 2 is secondary to another process, while the type 1 is secondary to a process developed inside the coronary arteries. Is this the main difference, or there's something else?
So yeah, just touching a point on the point that was confusing you, the coronary embolism. let's say you have a 40-year-old or a coronary dissection, 40-year-old male patient who's a cocaine user. You don't know that the patient is a cocaine user. He's coming with a vasospasm. The patient is coming with a STEMI. So the vasospasm led the vessel to be occluded. Can sometimes be fully occluded to the extent that it's fully occluded, and the patient can present with a STEMI. So that patient, unfortunately, what will happen is that everyone, which is I think justifiably so, will give the patient antithrombotic treatment. The patient will be rushed to the lab. It will not differ much anyway, because actually the vessel has collapsed on its own. So the two walls of the vessels has collapsed. So there is nothing to dissolve. The patient will receive the antithrombotic treatment. And then when the patient will go to have the coronary angiogram, you will find that there is a significant segment of the vessel. If the spasm is persisting, you will find a significant segment of the vessel actually stenosed with a very big mismatch to the segment prior to that stenosis. And at that point, what the interventionist will do will inject the coronaries with nitrates to see if this is going to relieve the spasm. And if this happens, then the interventionist will say that the patient developed a type 2 MI due to a coronary spasm, and then further history will be taken because the patient is a cocaine user.
So the diagnosis or the determination of the type happen after doing
so these 3 points is basically as an explanation, as it is at the start of the presentation, but actually in real life it will be at the end when the patient have an angiogram.
Okay, I understand.
Does that make sense now?
Yeah.
Okay. And that's basically in this bit here, they removed the presence of a thrombus from the end of the definition. So it's the same thing if you compare this one to the text here, but it's the only difference is there is the presence of a thrombus. And even if you, for example, missed or justifiably given a patient an antithrombotic treatment because the patient is presenting with a STEMI, it's important to differentiate between type 1 and type 2 MI, not only because of the acute phase, because the patient is not in need of antithrombotic treatment afterwards. The patient afterwards will be in need of vasodilators, the patient will be in need of a heart failure medications, and the patient will need to be educated to stop using the cocaine because this has happened secondary to that. So even if it's not helpful in the acute phase, it's helpful on the long term. Okay.
Yeah, that's completely understandable. Yeah, that's fine.
And then the type 3 MI is basically, unfortunately, that was not discovered except after death. So in summary, someone who's having a cardiac arrest, cardiac death, and the symptoms prior to the death was suggestive of a myocardial ischemia. Like, for example, someone who I saw my grandfather clenching his chest, having and saying that he has a chest pain, and then suddenly had a cardiac arrest. So, and then he went to have an autopsy. They found an evidence of an thrombosis. Then that's a type 3 MI. That's basically very academical, not relevant to clinical practice, I think. This is just there. I'm putting it there just for the sake of the complete explanation of the different types of the MI. The only thing that also I think would be helpful is the type 4 and type 5. This is a very heavy slide. I'm going to break it into different slides, but I'm just putting it there here in the slides when I send the slides over if someone wants to read it furthermore. But basically the type 4 and type 5 MIs are related to cardiac procedures. And why did the controversy come by? The controversy come by because, for example, when you are a cardiologist, let's say this is for the sake of this has been implemented for the sake of cardiologists, or for the sake of someone who's reviewing a patient in a district general hospital after they have been transferred from the tertiary hospital as an on-call. And I think Mohsen encountered these patients a lot. Someone has been transferred back from Blackpool after having a primary PCI, and the patient actually developed a STEMI, and he went directly from Preston, for example, this is the site that I'm based at, to Blackpool, had the PCI, stayed there for 3 days, and then was sent back to Preston to continue either cardiac rehab or whatever the case is. Let's say that this patient on the day number 4 at day number 5 developed chest pain, and as a very safe physician, which is justifiably so, you asked for an ECG and you asked for a repeat of the troponin levels. And when you've seen the ECG is completely fine, but you've seen the troponin levels raised. How can you interpret the troponin levels? And if we go back to the definition of the myocardial infarction in general, you need a rise or a fall, and you need an ischemic changes on the ECG, or ischemic symptoms, or development of new pathological Q waves, or having an evidence of a new myocardial loss. So what will happen in that case is that you need to interpret the troponin levels into a certain context, and that's why it was very important. And I'm just going to explain the context furthermore. You need to have either from the start 5 times, let's say that this patient came back to have a normal troponin levels. So he had a troponin of 1000, went to Blackpool, had the primary PCI, and then came to Preston, and for some reason someone did a troponin on him coming back to Preston, and it was completely normal, and then developed a chest pain 2 days later. If the patient developed a chest pain 2 days later, this is your question, Mohsen, at the start of the presentation. It needs to be the absolute value 5 times higher than the upper reference limit.
I can ask a question, please?
Yeah.
I'm sorry. Is that cardiac surgery would affect the troponin levels or no?
That's type 5.
Oh,
so that's
sorry.
type 5. No, that's fine. Yeah, no problem. Yeah, cardiac surgery will affect 100%. Sorry, it's just the slides are playing. So the difference between type 4 and type 5, think of it as a one entity. It's related to cardiac intervention, but type 4 is for coronary related intervention. They want to say by that PCI basically. Or
what is PCI?
No, what?
Percutaneous.
Yeah, so it is percutaneous coronary intervention.
Intervention. Oh,
yeah.
Okay.
No problem. And by that point, by that time, you need to have 5 times of folds higher than the upper reference limit. Or if someone who does not have a normal troponin at the baseline, you need to have a change of rise by 20%. Okay, but however, they go again and explain that the absolute post-procedure value must still be at least 5 times of the upper reference limit. So whatever happens, if you see that patient in 2 different contexts, either this patient is coming back with the baseline troponin is 0 or normal, and then develop the chest pain. So you need to have from this, in order for you to consider to discuss again with the tertiary center, or to reload that patient with antithrombotic treatment, you need to have 5 folds higher than the upper reference limit of your lab results, normal lab levels. Or if the troponin is raised, you need to have 2 things. You need to have a variation more than 20% from the last known troponin raised that you have seen on the patient, and the absolute value, which is basically, let's say the patient, the upper reference limit in Preston is 20, the patient's last troponin is 1000, or not 1000, let's say the last known troponin for the patient is 150. You need to have a 20% rise or variation of that 150, and anyway, by that time you will have a more than 5 folds higher than the upper reference limit. Then at that point, you need to consider that this patient is having an MI post the PCI. And why is this important to differentiate it? Because if it's less than that, or it's not meeting that criteria, then possibly the patient is having a chest pain because he's not optimized on his anti-anginal medications. So there's no need to reload the patient again, and the proper management for that patient at that point to optimize his anti-anginals. Does that make sense regarding the PCI itself?
Yeah, it makes very sense for me, because I've been discussing what similar case, not in the hospital, in our one of our friends. Anyhow, we might discuss it after the session.
Yeah, it's fine.
So that is explain that the patient post doing BCI, he is already, his troponin is high. Should be high for how long?
So I have a slide at the end showing how much the troponin can be elevated for, but as a graph. But in general, in developed countries like the UK, you have a very high sensitivity troponin. So back, for example, when I was practicing cardiology in Egypt, we used to say that the troponin can be raised from 7 to 14 days, but we weren't using high sensitive troponin at the time. The benefit of high sensitive troponin now, two things, is that basically it has a massive peak at the start. So you can catch the patient quite quickly. You do not need to wait for 6 hours or 3 hours to see it's a rise in the troponin. And also because it's high sensitive, so any improvement in the cardiac muscle outcome, it has a lesser time, resting duration than these 7 days. I would think as an absolute number, I cannot remember on the top of my head now how high the high sensitivity can be, but I would definitely think it's much less than 7 days. But also there is another thing that is very important to consider. Half of the patients that will develop an MI, for example, can have a heart failure, can have an element of hypoxia. So it moves on from the acute phase, moves on to the patient has a chronic stressor like hypoxia because of heart failure or due to low cardiac output. So the troponin levels might fall down acutely quickly, but will plateau afterwards. So it depends on the context of the patient that you're looking at. If the patient, for example, had a straight PCI, found to have a good heart function afterwards, the patient is fine and well, I would expect the patient to have a normal troponin levels within 5 to 7 days maximum. Okay. Does that make sense?
Yes.
Yeah.
And then type 5 is basically related to CEBG or cabbage, as we say. But at that point, because the extent of the manipulation around the cardiac muscle is very big and very intense, and not only the manual manipulation of bypassing a blocked artery, there is some technicalities around an on-pump procedure or an off-pump procedure, or a patient having an element of hypoxia during a long surgery, or a patient has bled a little bit more, or had developed hypotension while the patient is actually getting the bypass being grafted on the spot. So there is a lot of things can go on within the cardiac surgery that can lead the patient to have a high troponin levels, and as a result there is a difference in the troponin levels. So compared to the PCI, it's more than 5 times, and the CEBG is more than 10 times, and that's why they doubled the rate, doubled it compared to the PCI, because when you do a percutaneous coronary intervention, the amount of manipulation is only inside the vessel. So there is no and there is no other stresses that can happen. Sometimes complications happen, but let's say a straightforward thing, you just pass the wire, put a balloon in, just inflate the stenosed area, and then put the stent in, and then move away from the vessel. That's basically as 3 simple steps. But in the cardiac surgery or the bypass surgery, you need just first to have to consider whether the patient is going to be done on a pump. So basically another machine pumping the blood vessel, or off pump, like for example on a beating heart, or the patient developed a hypoxia during, for example, intubation or extubation, or the patient developed a hypotension because of the amount of the bleeding, or the patient developed an element of hypotension. And because there is a lot of possibilities going on, and all of them can happen in one setting actually. So the patient can need to have a troponin levels above more than 10 times above the upper reference limit. And it's also, again, going into differentiating them either with a normal baseline troponin level, so it needs to be more than 10 times, or in a patient with an elevated peri-procedural troponin, which have been stabilizing or falling. The post-procedure need to have a rise or a variation of rise of 20%. However, also the absolute post-procedure needs to be more than 10 times. Does that make sense?
Yeah.
And also it goes into the same thing, development of a new pathological key waves, angiographic documented new graft occlusion, because the difference here is the patient, you already bypassed the problem of the patient. So if someone's having an occlusion and it's not treatable by PCI or not amenable by percutaneous intervention, then you already has inserted a graft beyond that occlusion. So you need to find the thrombus at the graft occlusion site. But that's also technical for cardiologists. But for the sake of physicians on the wards or in ED or in ITU, this is how you need to interpret the troponin levels. in a cardiac surgery. Is that clear?
Yeah, very interesting.
Yeah, so just doing a quick recap, type 1 and type 2, you do not need to have all of these values. The reason for you to just to know about the difference between type 1 and type 2, just for yourself to put it into clinical context and to justify that I'm going to prescribe antithrombotic treatment for the patient in the context of another type 2, that you are not going to prescribe an antithrombotic treatment because there is a pathophysiology that can explain the patient is having a myocardial infarction. And in these two instances, you need to have a rise or fall. You need to have a rise or fall by at least one value above the upper reference limit, and then the symptoms afterwards. Type 3 is purely academical. You do not need to know about it except that it is discovered after leading to cardiac death. And type 4 and type 5 is important. Why? Because it's post-procedure. So if someone had a STEMI or had an MI and had an intervention and developed a chest pain, and you found a troponin more than 5 times, then do you consider revascularizing that patient? Do you consider thinking the patient to have an antithrombotic treatment? I think this is very justifiable. In a type 5, this is just need to be more than 10 times as well. I hope that was sufficient enough. I don't know whether anyone wants to log off or have another questions. I only have a couple more slides around the interpretation, just to ease any concern. Basically, is anyone happy to continue, or anyone? Do you guys want to send you the slides and then you can read it on your own and then send me a message whenever you have any questions?
I think it's over to you, Omar.
I don't mind, but because I know it's Friday, people might have commitments. I don't think I will continue more than 10 minutes, but just because I know people might be short on time.
What I would like to do is, because this session is recorded, I want to be perfect, and it was amazing from the start. So
carry on, Dr.
If you don't mind, please carry on.
Can you see the slides, or can you see the slides, or has it been stopped sharing?
I still can see it.
Yeah, okay. So that model for interpretation of myocardial injury, so we're basically recapping the situations all together. So you found the patient have an elevated cardiac troponin above the upper reference limit. You need to ask yourself 2 questions. Is the level stable, or there is a rise or fall? If the levels are stable, then the patient most probably will have what we call a chronic myocardial injury. And the chronic myocardial injury is very common, for example, in patients with CKD. You can see on the wards, sometimes you can see that the patient is having a troponin of 30s, in the range of 30s, and they are non-CKD stage 3 or stage 4, and you can say that this is due to the CKD, for example. Or someone is having chronic anemia, like, for example, HB of 90s, and it's been stable like that, and someone did a troponin on the patient, and it's also within the same range. There is no rise or fall. But if you found that there is a rise or fall pattern of the troponins, then you need to ask yourself, is it due to acute ischemia, or is it without acute ischemia? So if it is without acute ischemia, and in that case, for example, let's say sepsis, and patient doesn't have any cardiac symptoms at all, and the ECG is fine, and the patient and the troponin is done on admission as a baseline, as a part of the recommended evidence, then this is an acute myocardial injury, and it's possibly due to sepsis rather than anything else. Or, for example, something very famous, you can say that the patient is sorry, just to recap about that, the sepsis example stands. Sorry about that. But in another context, in sepsis as well, the patient doesn't have any ischemic changes, but the patient is having an ECG changes, like new ST segment depressions. So that patient is having a new ECG changes. So now the patient has moved on from a myocardial injury to an acute myocardial infarction, because you actually tick 2 boxes. One, there is an acute rise or fall. That's the myocardial injury bit. And you also found a new ECG changes. So that's a myocardial infarction. Now we move in to ask ourselves whether this is atherosclerotic or thrombosis driven, or this is a supply and demand by the oxygen due to the oxygen supply and demand imbalance. Probably will be the the imbalance between the oxygen supply and demand, and as a result, this will be considered as a type 2 MI. Does that make sense?
Yeah, it does, but I will leave my question at the end because it will open a big debate. So carry on, please.
Okay, that's fine. And also they are putting here at the end, I use the sepsis and the CKD examples because they are very common, but you can have also different types as per the ESCs trying to show you at the end of the slide here. And then moving on, these are cases that I've actually seen in the past 3 months. I know them because I've seen them on the acute take or while I'm being on call. So I know what happened with the patients when I saw them, and I know what happened afterwards. The only thing I want to apologize for is that these cases I didn't have the ECG with me, but I remember them from my clerking and or my review, and that's why I put them there just to show this in clinical context. So this was an actual patient who's before moving into the cases, anyone want to discuss anything? That's fine. So this patient is a 45 years old male patient known to be smoker and known to have a positive family history of a premature coronary artery disease. And the patient is admitted with a chest pain, and the chest pain was of a typical cardiac nature and has been occurring on exertion over the past 2 weeks and currently present until at rest. The patient's ECG was sinus rhythm and had a T-wave inversion from V1 to V6. The first troponin was done by ED was 145, and the second troponin done on while the patient was being clocked was 675. Do you think this is type 1 or type 2 or other types? Anyone wants to answer, or do you want me just to tell you the?
I think it fits in type 1.
Yeah, exactly. So it fits in type 1 because first the clinical context is the patient is within the age group of the patients, middle-aged man. The patient has a risk factor, which is smoker. Positive family history. His father had an MI while when he was 50 years old, and the patient has been experiencing chest pain, which was on exertion. So possibly the patient was developing an angina at the time, but now the chest pain was significant enough to be present at rest. And you also found an ECG changes. So it fits all the boxes of a type 1 MI. The patient has a risk factor, it's right age group, the patient has an ECG changes, and it's probably driven by atherosclerosis. So a type 1 is accurate, and it's probably you need to give the patient antithrombotic treatment and also other medication, which is important as beta blockers and statins as well. So that's the first case.
Until proved otherwise.
Until proved that it's either coronary embolism or
maybe a cocaine user or something else.
Yeah. Until so he will move into that pathway until he goes to the angiogram and proven otherwise.
Okay, thank you.
Okay. Yeah. And then the second case. So it's more complicated a little bit. This is an 89-year-old gentleman who was known hypertensive, and he's ex-smoker, and that's it regarding his medical history. His clinical frailty score is 5. He doesn't have any carers. He mobilizes with a stick if he's going uphill. Otherwise, he walks slowly when he's walking on a flat surface. He was admitted because of shortness of breath on exertion and also a productive cough. But all of these symptoms developed 4 days prior to the admission. And he's adamant, I took the history from him, and he's adamant that he doesn't have any chest pain. The blood results shows CRP of 120, white cell count of 17, neutrophils of 13. Troponin first set was 460, and the second set was 580, and he had a normal kidney functions. The chest X-ray showed the pulmonary edema and showed the right basal consolidation. The ECG showed the sinus rhythm with the right bundle branch pattern of the QRS and ST segment depression in the inferior and the lateral leads. And unfortunately, we didn't have any previous ECGs to compare. So to recap, he's a relatively healthy, nearly 90-year-old gentleman coming with shortness of breath on exertion and productive cough. Symptoms started very shortly before admission, and he denies the chest pain. He has high inflammatory markers and high troponin levels. He has a chest X-ray shows evidence of heart failure and an infection, and he has an ST segment changes as well. At that point, when you're reviewing the patient as you've been called to see him or this patient's on your ward, what do you think is happening with that patient? Is it type 1 or a type 2 MI? If no one knows, it's fine. I can explain to you what happened and what
seems to be there is a secondary cause, or yeah, it seems to be type 2.
Okay, I think
that's the debate I was about to talk about, because anything can be fitted under type 2. I mean, at this stage, if I'm the first one seeing the patient, I'm gonna think about it's type 1. But when the pneumonia gets worse, and he have respiratory failure second to that, and maybe septic shock as well, everybody will say it's type 2. So why it's not type 1? That's my question.
Okay, yeah. So why it's not type 1? That's basically, you both are correct. You can justifiably say that this is type 1. You can justifiably say this is type 2. And this gentleman is actually that gentleman here in this slide. The gentleman with the underlying atherosclerotic vessel here. This is that gentleman. So if you did an angiogram on the gentleman, this is actually what you will see, that he actually has a stenosis. The patient probably has a coronary artery disease, but probably either was triggered by infection, or actually he had a type 1 MI and then had an infection afterwards. It's very difficult to tell in that patient. So what happened actually in real life with that patient? The bleeding risk was assessed with the patient. Fortunately for that patient, I remember it was a Wednesday morning. My own rationale was, that's basically what I explained on my clerking and to the consultant reviewing the patients afterwards, that I think the patient has a risk factors to develop type 1 MI. I think the patient had symptoms developed subacutely, and I think he's presenting with heart failure, which coming with a pulmonary edema. And if this is secondary to only right basal consolidation and chest sepsis, normally these patients doesn't develop pulmonary edema. They can develop symptoms of heart failure, but not requiring high levels of oxygen. And I said, because that's basically what I wrote, because I cannot totally differentiate between type 1 and type 2, the risks, the benefits of giving him antithrombotic treatment, in my opinion, outweighs the risk. And I requested an urgent echocardiogram and an urgent cardiology consultant review. And what happened is that the gentleman had an echocardiogram afterwards, showed that the function is less than 35%, and showed also hypokinesia on the inferior wall, and showed that the anterior wall, which is basically the wall supplied by the an LED, which is the main artery, is not moving at all. At that point, the cardiology consultant agreed to continue with the ACS treatment, and this patient was discussed with Blackpool. Blackpool explained that to stabilize the patient first, if the patient doesn't need high levels of oxygen, the patient should be transferred for them afterwards. What happened at the end, unfortunately, that patient developed significant pulmonary edema, and he remained in the CCU here. He couldn't. He was on 60% oxygen and he couldn't lie flat. He was continued on the ACS treatment and continued on the treatment of sepsis, and unfortunately didn't survive. It's difficult to tell in this scenario, but I'm just highlighting that scenario specifically because I would just want to say that even experienced physicians or even some scenarios can be difficult to differentiate. But as long as you have a logic that you can defend and a logic that you are confident of in terms of balance, always consider the balance rather than the absolute indication. It is completely justifiable to give the patient an ACS treatment, and it's completely justifiable to think that this is type 2 MI. I only had some insight because I have never seen a type 2 MI that develops within a couple of days that makes the patient have pulmonary edema, and I also was fortunate enough that this was not during the night or was not during the day, and we had a formal echo done which showed evidence of loss of myocardium and the cardiology review.
I'm sorry, a question that fly on my head. There is a question. Whatever the type 1, type 2, if I consider them as a type 1 to give him antibiotic treatment until proved otherwise, until doing the investigations, what will happen?
So what will happen is the next case. So what will happen is the next case. But what will happen, for example, the only thing I'm trying to highlight, either the patient can develop a complication from these medications, which is bleeding, it can be life-threatening bleeding, or it can be completely unjustifiable, for example, and the patient's family can come and complain, and you cannot say that for sure why you have done that. The whole purpose of this presentation is that you can justify what you're doing in that clinical context, because this clinical context of this case especially is very difficult. And I don't think anyone would be blamed if they gone both ways. But the take-home message from this case is that this is subacute or acute, and it is rarely in my practice, I don't know whether Mohsen agrees or anyone else agrees, that a type 2 MI is significant enough to make the patient coming with a pulmonary edema. The other thing just to highlight in the history, but I think this is very subjective, how much you want to interpret it. He first complained of shortness of breath on exertion, and then he developed a productive cough. So there was some exertional symptoms, which in some people's perspective, it can qualify as an ischemic symptoms. Also, someone else can argue that these shortness of breath on exertion is due to the pneumonia. So it's very difficult in this situation, but I think due to the subacute nature, the patient being nearly 90 years old, so probably the patient has some form of atherosclerotic coronary artery disease, and also the patient being hypertensive and a previous smoker and subacutely or acutely unwell with a pulmonary edema, I thought that the balance of all things lies within giving the patient an antithrombotic treatment.
One more thing before we move from this case. Regional wall motion abnormalities is not specific for type 1, isn't it?
You can find regional wall motion abnormalities in myocarditis. You can find regional wall motion abnormalities due to tachycardia. It depends on the regional wall motion abnormalities is a spectrum. So if you go back to the definition, sorry, I didn't stress about it because I thought it is not important for the sake of the presentation, but since you asked, you need to have the regional wall motion abnormality in a pattern consistent with an ischemic etiology, and that's very specific in imaging. So you need to come and tell me that actually the anterior wall of the anterior wall is hypokinetic and the anterior septum is hypokinetic. When you tell me the anterior wall and the anterior septum, this basically forms a territory of the LED. On that's basically what it justifies.
So if I've got this wall motion abnormality that respects the anatomy and the blood supply, can I be confident on saying this is a type 1 MI, or it still can be a type 2 as well?
So you can be confident in justifying that this is type 1. You will never know, or not you will never know, you will 100% be confident when you do the angiogram.
Okay.
In this situation, in this patient, in this patient.
I think I'm asking at a ward level decision making, like an ICU. I did a quick echo, and I can confidently see a regional wall motion abnormality covering anterolateral wall and anterior septum and whatever, and everybody is saying no, it's type 2 MI. So
no,
because it happens, and you know it happens.
So it depends. So can you tell me more about that clinical context, or you don't have enough time?
No,
you want to discuss it later?
It's just that was the question I was.
No, so the question is not. So
I think type 2 sometimes is
so as per definition
overdiagnosed, isn't it?
Yeah, that's 100%. It's overdiagnosed, and sometimes it overlaps with type 1, and people easily dismiss type 1 and miss giving the patient the treatment it should be given. So if you go here in type 2, you can have, as per the definition, a new regional wall motion abnormality in a pattern consistent with an ischemic etiology.
Okay.
Okay.
So it's nothing to use to differentiate.
It is one of the things that you need to consider if there is. So the purpose of this is basically patient can have a pattern of an ischemia. Going back to this one, probably Mohsen, if the patient having a type 2 MI and they have a regional wall motion abnormality consistent with an anatomical artery, probably this artery is affected already.
Yeah.
Okay, so that's probably this vessel. If you go and done the angiogram, you will find that this is the patient.
Yeah.
So, and in this context, the most important take-home message is for someone who's doing medical reviews on constant basis, is if you feel that the patient has a risk factors for coronary artery disease and you cannot tell properly, or not properly, you cannot tell for sure with complete confidence, just look at the balance of what is the risks of me giving them that treatment and what are the benefits. And if you feel that the benefits outweighs the risk, then you are justified to do this in the best interest of your patient. And let's say, for example, someone's coming with an iron deficiency anemia with an HB of 50, but they are known as ischemic patients. So you have a clear explanation, but it's not usually that straightforward in some of the cases. So the take-home message from your question is you can have an underlying coronary artery disease that was unmasked by a mismatch of an oxygen supply, which is then a type 2 MI, and that's why you're having regional wall motion abnormality in the echocardiogram. But the context of the case is bigger than that. It depends on the symptoms. It depends on what you're reviewing on the patient as well. So, for example, if someone is having regional wall motion abnormality and they have a normal heart function, but it's different than someone's having regional wall motion abnormality and developing a pulmonary edema and having a heart failure. So I would be more justifiable to give the ACS treatment in the patient who's having a heart failure, and I can wait and discuss with someone who's not having a heart failure at the moment because there is no significant damage yet done yet.
Yeah.
Does that make sense?
Yeah. Thank you.
Case number 3. This is basically what will happen if you give the ACS treatment in a not indicated case. So that's a lady who came with an 84 years old female patient known to have dementia, has 2 carers daily, lives alone, and admitted due to fall and a right humerus fracture and a long lie. She was found to have an AKI stage 3 and a raised CK. She had 3 sets of troponin done, 80 and 200 and 160. Her ECG shows AF, and she's already known AF. Her heart rate was 130 at the time, but there was no ischemic changes at secondary to that heart rate or secondary to the situation in general. What do you think happened with that patient?
This is not an MI.
Okay, yeah. So what is the terminology for that rise of the troponin in that situation? That's the myocardial injury. That's the myocardial injury that we're talking about.
But this is not an MI.
Yeah, that's not an MI. Yeah, that's the myocardial. So the rise of the troponin is an injury, is a reflection of an injury happened to the heart muscle due to the acute kidney injury, due to the raised, the long lie, due to the trauma itself, ongoing tachycardia. All of that can explain the troponins. What happened with that lady, unfortunately, that because someone justified that the fall is due to cardiac event, and all what happened is secondary to the fall. So the patient had a cardiac event, had a fall, fractured her humerus, and stayed on the floor for the long time. Can happen. It can happen.
In this case, if he gives antithrombotic medications, she will have a lot of bleeding, and she will like
that lady had the 4 grams drop in her HB and had a massive hematoma from the humerus to her wrist.
Yeah.
And so everything was stopped. Even the AF, the anticoagulation for AF was stopped. Everything was stopped. She received 3 units of blood. That lady remained on the ward for a couple of weeks and developed a stroke. And she unfortunately passed away. So what happened in that context is that the patient was exposed to an unnecessary medication. The patient had a complication from the medication, and because of that complication, even the indicated medication in her case, which is the anticoagulation for the AF, was stopped. And probably, I might argue that she had a stroke secondary to the AF.
Excuse me.
Yeah.
So how they justify that the patient has an MRI without ECG findings or echo or anything else? Is the patient coming because of shortness of breath or coming presenting with fractures and so?
So
the
what
patient
happened
is
with that patient was it is one of the cases of the problems of the, I think in my opinion, the problems of the NHS. So that patient presented on the weekend, and she was seen by a physician who felt that there is no enough evidence to give that patient an antithrombotic treatment. And this patient was admitted on a bank holiday. This patient actually is, this case is being investigated currently, but the patient remained 3 days without any imaging available. And the patient was dementia, so the justifiable physician at the time, the physician who justified said that the patient has dementia. She might not be able to express her symptoms. And might have been, actually, it can happen sometimes. Someone has an MI and fall and presenting with a fall, and it can be an atypical presentation, but it's not usually always when you see these patients, you rush to give the antithrombotic treatment. And that's why I was explaining the balance. The balance is very important. And the balance here, the patient had suffered a recent fracture. And even if the patient is having type 1 MI, let's say she's having a type 1 MI,
she will die from hemorrhage more than the MI itself.
So she will suffer hemorrhage. Now, can I confidently say she will not bleed more than she would have more than from the heart failure or more from the ischemic burden? I cannot know. So the balance, the benefit doesn't outweigh the risk in that case. So let's say that the physician was correct, but the balance doesn't outweigh the risk. So that's why I was explaining the difference between these two cases. And that's the problem of prescribing antithrombotic treatment. You don't have enough evidence to either of the cases, either type 1 or type 2. If you want to take a decision, even if we think, for example, while we're doing this presentation, that this is a myocardial injury, not an infarction, doesn't qualify as an infarction, but if someone just thinks that this is an infarction and want to prescribe a type 1, an antithrombotic treatment for a type 1, there needs to be family discussions. Then there need to be clear documentation of the risks of the medications and what happens. So the next of kin can have an informed decision. And let's say in another context this has happened, and actually the physician was right, the patient had an echocardiogram, showed the regional motion abnormality, the patient improved and then went to have a PCI, was found to have actually a coronary artery disease and had an intervention, then that's fine. But the problem here that we're highlighting is that the benefit doesn't outweigh the risk. There is no clear evidence to either of them, and there was no informed decision taken.
Yeah, let me ask this silly question. What is meant by long lie?
So long lie, basically something said in medicine for someone staying on a certain surface for a prolonged period of time, enough to cause the patient to have a rhabdomyolysis.
Oh, yeah.
And that's why I'm just highlighting the raised CK. I don't know whether Mohsen agrees or does he have another understanding of the long lie.
No, that's fine. Yeah, and it's for me the confusion about the troponin, but you answered this already in the high sensitivity troponin, that it's more specific for the myocardial injury rather than anything else.
Yeah, and there is the slide of the myocardial troponin is after the slides, but after the cases I wanted to put it on after the cases because so you can have an understanding of that curve after you've seen the cases, and I explained all that as well. Just quickly, the last case 4, 65-year-old female patient. She's known ischemic heart disease. She had an NSTEMI 2 months prior to the admission to the hospital, and 2 months before admission to the hospital, she had a function of less than 35%, and she was awaiting viability studies to see if actually the myocardium is viable. So she was going to have a cardiac surgery. So she's straight on the board, is being prepared to have an intervention, and she presented to ED due to chest pain, but the random bloods were done. HB was 55. She had a low MCV, and the troponins were raised to 100 and 600. The ECG shows sinus rhythm. The ST segment depression in the inferior leads were new, but the key waves in the anterior leads were old. What do you think happened with that patient?
That's a new myocardial event for me.
That's a new myocardial event. That's a correct terminology, but which myocardial event?
Type 2.
Yeah. That's a type 2 MI. So you have an explanation, a clear explanation of why that patient actually is coming with a chest pain. Someone with anemia can come with a chest pain. So that patient had a symptomatic iron deficiency anemia, enough to cause her to have a type 2 MI, and enough to cause her to have an ST segment changes. And as Mohsen said, the umbrella of the term is a myocardial event. Now, what happened
It's
afterwards?
a skip door.
No, but actually that's true. That is a myocardial event, but it's difficult to justify to completely say that this patient didn't develop a type 1, but more plausibly, this patient developed a type 2 because there is an acute change in her HB. But let's say, for the sake of academic and the presentation, the patient went to have another repeat angiogram on the RCA, and they found that the RCA actually has a thrombus. Someone can develop. The patient was actually very anemic to the extent that she developed another myocardial event. That can happen, but for the sake of that presentation as a physician on the ward or in the ITU, I think it is very reasonable to justify that this is a type 2 MI. You just transfuse the blood, correct the iron, and then refer back to cardiology, and I'll discuss with cardiology whether we can expedite the intervention for her.
If the patient gets an antithrombotic treatment in such low hemoglobin levels, and develops bleeding, she will die, definitely.
So now that's my next question. What would you do after correcting the HB? Whether you consider this due to bleeding or due to another cause of anemia, like nutritional or supplemental cause?
She has a chronic, low MCV, so it's probably a chronic one.
Yeah, so what happened that this case was discussed between gastro and cardiology, and gastro, the patient who saw her, the first one who clogged her, has actually done a PR exam and they didn't find any melena. Gastro explained that this is unlikely due to the presence of iron deficiency anemia, that this lady is having an ongoing bleeding, and also when she had the iron level, the iron infusion and the HB infusion, her HB was above 90. Gastro said that's not for intervention for the time being. Cardiology changed her antithrombotic regimens from aspirin and ticagrelol to something less potent, which is clopidogrel. And probably this patient, when she will have the intervention, she will continue and go to have the intervention. But this didn't happen yet. But my insight would be that she will be on single antiplatelet. So she will receive a dual antiplatelet for either a week or 1 month, and then going to be continue on a single antiplatelet only. And she will not continue on the dual antiplatelet for 1 year because, as per gastro justified, she doesn't have an acute bleeding. Now, in another scenario, if she's having for example, a gastric ulcer or a duodenal ulcer, then all cardiac interventions will be stopped. Does that make sense?
Yeah.
If it is an acute bleeding, you mean?
Yeah, like acute bleeding, exactly. But it's also a difficult decision, isn't it, to justify either of them, whether you would wait and let the patient miss an opportunity to have a revascularization and probably have a prolonged life expectancy, or would you take the risk and give the patient antithrombotic treatment afterwards, and you might take your chances. She might not bleed and she might bleed. So that's why the balance is important, benefits and risks. And patient's decision.
I took it from that the patient hemodynamically looks stable and low HB, low MCV. It looks like something chronically happening over time. It's not like acute bleeding now. And with all these risk factors, ACS treatment might be justifiable, but as you said, it's
I would
personally prescribe her ACS treatment. I would optimize her anti-anginals and transfuse her and give her iron, and discuss with cardiology that now that we have this situation, and that's what actually cardiology requested, to discuss with gastro, and actually it was a joint decision, and the patient's family was involved. So they ticked all the correct boxes. Now, if the patient developed a bleeding in the future, then they explained the risks, they explained the rationale, the specialists were involved, and it was a calculated risk. But for the sake of the situation that you're reviewing this patient for the first time, this is type 2 MI, and an ACS treatment wouldn't be indicated. from my point of view, to be fair. Does that make sense?
Yeah, that's why we call cardiologists. We don't take decisions.
And that's the curve that everyone is asking about. So that's why there is a rise or fall. So this is a chronic, this is the rise in the troponin values in a chronic myocardial injury. So you have this variation, just slight increase, slight decrease, slight increase, and slight decrease. That's the normal upper reference limit of the lab. And that's the troponin itself in a peak event, in an event. So it peaks very quickly, and then that's an early sampling. So you might actually do the troponin at that point. And if you did the troponin at that point, it will be normal. If you did an early sampling, so you will find it rising. It's difficult to tell where did you catch it on the curve. If you did a later sampling, you will find it to be plateauing. So for example, it's on around 400 here. Sorry, my cursor has been lost. 400 here and 500 here and then 600 here, and then started to fall again and to fall again and to fall again and to fall again. So that's why the fall is important, because the fall is indicative of a later or a very late sampling.
Yeah.
How many samples you are taking? If a patient is suspected to have an MI, you take several samples every 1 hour?
That's the answer. That's the slide. You're actually asking the right questions at the right time. Right time. So
good.
Yeah, that's a slide from other guidelines. It's called the non-ST acute coronary syndrome guidelines. It used to be, when I was in Egypt, we used to do 0 is basically an indicator at the point of review, the point of the patients being reviewed. We used to do 0, 3, and 6. I think Mohsen can relate to that. I don't know whether anyone else joining is from medical background. Now it moved into 0 and 1. So you only need 2 samples. Why? Because it's very early peak. So 1 hour is sufficient enough to cause a change from normal to more than the upper reference limit, or from upper the reference limit already, more than the upper reference limit, to a higher level of the upper reference limit. That's why they moved into, because of the new high sensitivity troponins, that's why you moved into 0 and 1 sampling.
So probably the one we use in our trust is not the high sensitive one.
Yeah, our trust is high sensitive.
They use 6 hours still. I don't know.
But that's not because of an updated information.
Okay.
That's another thing. Just I wanted to just let you guys see that basically you, in your own assessment, if you consider that this patient is a high risk of developing an ACS, then yes, that patient had needed troponin, second troponin anyway at 1 hour, and you need to admit the patient. If you think that the patient is high risk, go to CCU. The easier one is, for example, the patients that you see in ED, that actually the pain is very atypical. The patient is diabetic. You only want to make sure the patient's symptoms has improved. You want to make sure and look after your patient. You want 2 samples. If it's very low or a low risk, it's justifiable to do 0 and 1. If then 0 and 1 are fine and the ECG doesn't show any changes, then this is ruled out. But that doesn't mean that the patient doesn't need further investigation. It means that it ruled out as an acute event. Further investigation or not, depending on the patient's background and then the patient's risk factors. Is that okay?
Yeah.
And that's the ACS treatment, just for you guys to be aware. And I'm putting the slide here, and because that would probably what will happen in that patient, that lady here.
Yeah.
That probably what will happen. So you have 3 approaches. You have either you consider, this is a slide where you're considering the bleeding risk of the patient. If it's a low bleeding risk, so ideally you will have antiplatelet aspirin and prasugrel, or aspirin or ticagrelor, aspirin or clopidogrel, ideally for 12 months. You can extend beyond 12 months, or you can stop at 12 months based on other topics. This is something else called the ischemic risk, or you can only consider on dual antiplatelets for 3 months. But if you're going to consider dual antiplatelets in someone who's low risk, you need to continue to pick the ticagrelor, not anything else, and you continue with the ticagrelor rather than the aspirin. If you're considering that the patient is very high risk, like that lady that we were discussing, she will only receive a choice of clopidogrel and an aspirin for 1 month, and afterwards we'll have a clopidogrel afterwards throughout. And that's probably what will happen with that lady.
Yeah.
There was more evidence coming out that you can actually use it for only 6 months, not 12 months as well. But depends on technical issues on intervention and what's the difficulty of the intervention and all of that stuff. I hope that topic has been made not clear, but just giving you a good base in order to assess these situations. And I think that's the end of my talk. And these are the guidelines at the end of the slides if anyone wants to refer to them.
Thank you very much, Dr. Omar. It was very interesting.
No, at any time.
I believe I will forget everything in a few minutes.
Yeah, that's fine.
Thank you very much, Dr. Omar. I'm sorry for leaving you after your long day for all this time, but it's really interesting. And if you open more for questions, it will never end. I'm really glad that I have it on recording so everybody else can see it.
Yeah, that's fine. I'm on the group anyway, so feel free to get in touch if you have any questions, and I'm happy to be approached at any time.
Yeah. Thank you very much for being with us. It's really an interesting topic. I'll prepare the feedback forms as usual, and we'll let you know. I think I will give more time because we have so many people with medical background in the group, but unfortunately, and they will know that they were unfortunate not to attend this lecture. I will leave it for them to review the video because it's really a big question that happened every day with anybody who works in a medical or maybe an ENT ward as well.
I agree. It happens every day. I agree.
I will refer every patient with any troponin levels.
Yeah, the important thing is to be safe and referring a patient to being safe. So there's no argument.
Yeah. But refer while I am understanding what is the situation is different. Yeah. So suspecting something or something like this. Yeah. I'm very.
Yes, it's actually this is the sake of if you don't have a medical background, but you'll have a patient with a medical problem in your at least you shouldn't miss the patient. Yeah. We're not saying you have to treat the patient, but if you have a background about what's happening, you won't leave the patient without a decision. That's the main idea about it.
The troponin, I think, is done as a routine for every patient. We have a lot of patients, elderly patients with epistaxis. So it is done as a routine. I never ever have a lock on troponin for whatever reason. I never have a lock on it. So yeah, I will have a lock in the future to make myself safe. If it is raised or I noticed any changes, I will directly refer the patient. And also while in the ward, so if the patient develops any chest pain or something, until that the medical or the cardiac team comes to see the patient, I can understand what's going on. And thank you very much, Dr. Omar. You're a star.
Anytime. No, anytime. And I hope I made that area of embolus or dissection clear now.
Yeah.
Okay.
That's fine.
That's fine. Okay.
Thank you very much, guys, for attending. Mahmoud, do you have any comments?
No, it was actually a great presentation. I mean, it must have been difficult for Dr. Azab coming from ENT.
Thank you.
It's difficult.
Like a student, like a year 6 student.
It's difficult even for medical background, and it will continue to make problems everywhere in the world. I mean, Saudi Arabia.
You know that the problem has been started to be observed more and more because of the high sensitivity troponins. So because of the new assay, basically.
Yeah, but thank you. It was a great lecture, actually.
No problem. Anytime. Yeah, nice talking to you guys, and
thank you very much.
Just hope to see you in the future in person. Okay.
Yeah. Sure.
Yeah, definitely. Thank you very much, Omar, and have a nice trip back home.
Yeah.
And we'll see you next week, inshallah.
See you inshallah next
week. Thank you guys for seeing it today, and see you next week. See you. Bye-bye.
Thank you. Bye-bye. Alaikum salam.